So I'm really excited to introduce Dr. Mark Katzenbuehler. So, quick question for the room. Who here likes art? Art. Who likes art? I like art too. Really good art stimulates senses. Great art stimulates thought. What I love about Mark's work is that when you read an article from Mark's research program, you learn something, but his work also forces you to step back and think about all the different layers that are relevant to his constructs of interest. Mark studies stigma. The effects that stigma have on physical and mental health can occur on a variety of different levels that range from the interpersonal to the structural. And Mark will spend a great deal of time talking today about the structural part. In order to do that well, you're forced to think about not only the research and theory that's relevant to your primary area of training, but also all the other areas of training that focus on levels that you did not have as much training in as you might have hoped. A really great scientist that studies these kinds of processes, you don't know where they're coming from when you read their paper. You don't know where the clinical psychologist in them ends and the social psychologist in them begins. The epidemiologist, where does that end? Where does the sociology part of their work begin? Mark's work is like art, and I love hearing it, reading his work and following his work over time. I'm so excited that he's able to talk to us today. So I give you Mark Katzenbuehler.
Well, thank you, Andy, for that very nice introduction and inviting me to be part of this special issue and this great conference that you put together. I'm a terrible artist, so it's actually nice to hear that you think that I have some artistic skills in this area. Just by way of background, I am a clinical psychologist by training. But I'm also, I think, a closet sociologist, or I think I've come out of the closet maybe by now. But as you can see, my primary appointment is in a school of public health, where my office is next to two sociologists and anthropologists. We also have historians and health psychologists. And I also have a joint appointment in sociology. So my work draws on, you'll see some of the imprints of clinical psychology, but also see some of the influences of my colleagues in sociology and social epidemiology as well. I'm going to talk about some of the work that my colleagues and I and others have done in the area of what we call structural stigma and how it influences health and health inequalities. Because this research isn't always necessarily firmly in the clinical psych realm, I'm going to spend just a little bit of time giving you some of the background in this work in case you're not familiar with it, and then talk about some of the future directions for this field. So as some of you may know, in 2011, the Institute of Medicine, now National Academy of Sciences, released their landmark report on LGBT health disparities. And this report synthesized the large literature showing the really substantial health disparities here in the US related to sexual orientation and gender identity. Also talked about the work showing that these disparities emerge early in the life course. After the field over the last sort of 20 years or so has documented some of this epidemiologic evidence of these health disparities, the field really turned to try and understand some of the causes that are driving these disparities. And stigma has emerged as one of the most frequently hypothesized risk factors for explaining LGBT health disparities. So when you think of stigma, you might think about concrete events and experiences that happen to people, things like hate crimes and bullying, and being the target of stereotypes. And you might also think about the psychological responses that stigmatized individuals have to these concrete events and experiences. So things like anticipating rejection, being hypervigilant to threat cues in their environment, or concealing their stigmatized identities to avoid rejection. And you wouldn't be wrong. There's a large literature showing that these are forms of stigma that really matter for health. But it also turns out that this is just the tip of the iceberg in terms of how stigma operates to produce disadvantage. Stigma is much broader than these concrete events and experiences. It's embedded and promulgated in our social institutions through the laws and policies that we choose to pass or not pass, and also through the broad cultural and social norms that our society has about different stigmatized groups. Collectively, this is what my colleagues and I call structural stigma. And this metaphor of stigma as an iceberg is consistent with how stigma has been conceptualized in the broader literature as a multi-level construct ranging from individual to structural levels. So individual forms of stigma refer to the psychological processes through which stigmatized individuals both perceive and react to stigma. And psychologists, particularly social psychologists, have done a really elegant job over decades of research really identifying important individual level stigma processes. I've just shown two here of self-stigma and concealment. In contrast, interpersonal forms of stigma refer to the interactional processes that occur between the stigmatized and the non-stigmatized. And these can include overt events like bias-based hate crimes, but they can also refer to more subtle interactional processes like microaggressions. And the vast majority of research on stigma within psychology, but also medical sociology, has really existed at these two levels of analysis. And this work has been really essential in terms of documenting many of the ways in which stigma contributes to disadvantage. But at the same time, this work has been criticized for overlooking broader institutional and structural forms of stigma, which my colleagues and I have defined as societal level conditions, cultural norms, and institutional policies and practices that constrain the lives of the stigmatized. This underrepresentation of structural stigma relative to stigma at other levels of analysis has been called a, quote, dramatic shortcoming in the literature, as the processes involved are likely major contributors to unequal outcomes. So my program of research has set about to try and begin to address these gaps in the literature. And when I embarked on my research program in this area almost a decade ago, I decided that the most, I guess, the best way to go about showing that structural stigma mattered for health, if it in fact did, was to produce an integrated line of work that used multiple measures of structural stigma, used multiple methods to examine its relationship to adverse outcomes, conducted this work across multiple stigmatized groups, and examined a variety of different health outcomes. And the reason that this multi-measure, multi-group, multi-outcome approach is important is that if you can show consistent relationships between structural stigma and health inequalities across this range of approaches, it improves our confidence that these results are not spuriously confounded by any particular measure, method, or group, or outcome. So what I'm going to be focusing on today in my talk is just one group. I'll focus on structural stigma related to sexual orientation, though I know many of you also do work with numerous other stigmatized groups. And the theories and methods that we've applied to studying structural stigma as it relates to sexual orientation, I think are very relevant to other stigmatized groups. So hopefully, and we've begun to examine generalizability across other stigmatized groups as well. So my hope is that this might generate some ideas for you in your own work, even if you're not working particularly in this space. So I'm going to walk through, in the first part of my talk, just a couple of illustrative examples of this multi-measure, multi-method approach that we've used to study structural stigma and sexual orientation health disparities. Most of this work has actually been conducted with adults, so I'll be focusing on that work, but also mentioning work that's been done with youth where relevant. And then I'll pivot in the second part of the talk to talk about some ways that I think this work can be expanded in future directions. So in the first methodological approach that we've used to study relationships between structural stigma and health inequalities, we've capitalized on state-level variation in social policies that differentially target LGBT populations for social inclusion and exclusion here in the US. I'll just present one example of this work. I chose this study, it was the very first study I did in this area, and it is probably not the best demonstration of this work, but I knew there were many trainees in the room, and so I wanted to use as an example of how an early finding can end up sort of spurring a programmatic line of work that certainly helps you address the myriad limitations in your first study, but also helps you begin to think through some of the questions that this first study generates that you can fill in the gaps through future work. So in this study and others like it, our measure of structural stigma was state-level policy. So in this study, we coded states based on the presence or absence of two policies. These included hate crime laws and employment non-discrimination acts. And we coded them based on whether these states included sexual orientation as a protected class status. We then created a dichotomous variable comparing states with no protective policies versus those states that had at least one of these protective policies. And hopefully you'll forgive my perpetuating the red state, blue state distinction. I can't seem to get politics out of my mind these days, but I've shown here in red states with no protective policies and states in blue had at least one of these two protective policies. This was actually in the year 2005 because it corresponded to our outcome data, which I'll mention now. So we link these measures of state-level policies to individual-level mental health outcomes in a data set called the NESARC. This is the National Epidemiologic Survey on Alcohol and Related Conditions. It's a nationally representative survey of non-institutionalized U.S. adults. You can see there's a nice large sample size of nearly 35,000 participants. These are face-to-face interviews, and researchers use semi-structured diagnostic interviews to generate DSM-4 psychiatric diagnoses. So we had mental health outcomes on nearly everyone in the sample. And then at the time, this was the largest nationally representative study to include a measure of sexual orientation identity. And then finally, we knew the state of residence of these respondents. So we had all the ingredients that we needed to examine associations between these indicators of structural stigma and sexual orientation disparities in psychiatric morbidity. So let me walk you through these results here. On the y-axis are the adjusted odds ratios indicating the likelihood that LGB respondents met criteria for a psychiatric disorder relative to heterosexuals. And on the x-axis are the psychiatric disorders where we find a significant interaction between state-level policies and sexual orientation status. I often present this in public health audiences who don't know terms like dysthymia or GAD, so it's actually very nice to be presenting this in a clinical audience today, so I don't have to go through that. So I'll just launch in. So here you can see that for dysthymia, we see that LGBT adults who live in states with protective policies were no more likely to meet criteria for this mood disorder than were heterosexuals who lived in those same states. Or stated in another way, the sexual orientation disparity in dysthymia was eliminated in states with protective policies. In contrast, LGBT adults living in states with no protective policies were nearly 2.5 times more likely to meet criteria for this mood disorder than were heterosexuals in those same states. And we find similar results for generalized anxiety disorder. You can see here that LGBT adults living in states with protective policies were a little more than 1.5 times more likely to meet criteria for this anxiety disorder than were heterosexuals in those same states. But in contrast, LGBT adults living in states with no protective policies were nearly 3.5 times more likely to meet criteria for this anxiety disorder. I won't belabor the point, you get the idea here, but we find similar results for PTSD and for psychiatric comorbidity, which is we define as the presence of 2 or more co-occurring psychiatric disorders and is an index of illness severity. So the take-home message from this study and others like it is that the sexual orientation disparity in certain forms of psychiatric morbidity are significantly higher in states that had these structural forms of stigma. But we've also conducted some follow-up sensitivity analyses to try and see if there's support for plausible alternative explanations for these findings. So one plausible alternative explanation that you may be thinking about is, well, maybe it's just that high structural stigma states have a lot more interpersonal forms of stigma and discrimination against LGBT people. And so structural stigma is really just an aggregate measure of individual interpersonal forms of stigma, and therefore shouldn't exert an independent association with psychiatric disorders over and above stigma at the interpersonal level of analysis. Fortunately, the NESARC enabled us to examine this at least in a preliminary way, because they have measures of perceived interpersonal discrimination based on sexual orientation. So this is an item, or a series of items that ask people the extent to which they perceive that they've been discriminated against in a variety of interpersonal domains like education, healthcare, et cetera, specifically because of their sexual orientation. So we reanalyzed the results controlling for that measure, and the direction and magnitude of the results is largely unchanged. So this is important because it not only suggests that structural stigma may be independently generally associated with psychiatric morbidity over and above stigma and other levels of analysis, but it also suggests that the results aren't due to an aggregation bias. Another alternative explanation for this finding that you may be thinking is, well, maybe it's just that the healthy LGB respondents leave high structural stigma environments and sort into lower structural stigma environments. It would certainly be a rational response to living in high stigma context, but what that would do is it would leave the unhealthy LGB respondents behind. So what looks like a social causation story is really due to differential selection by health. We can't test that in the NESARC because it didn't include measures of geographic mobility, but we were able to test this in another nationally representative study called the General Social Survey that has measures of sexual orientation, geographic mobility, and self-rated health. And first you can see that there are very actually minimal sexual orientation differences in geographic mobility with, for example, the same proportion of LGB respondents living in the same city as heterosexual respondents. But the most important thing for a social selection argument is its relation to health. And importantly, we see that among those participants who report being in fair or poor health, sexual minorities are actually more likely to have moved out of state than heterosexuals who report being in fair or poor health. So that's actually the opposite of what the selection hypothesis would predict. So at least thus far, we've not found strong evidence that these results are due to differential mobility by health. Of course, another way, though, to if you're not convinced by that evidence, to test whether or not differential selection by health is operative is to conduct research with youth, who of course have a lot less choice over where they live. And so geographic mobility or selection by health is much less likely to be a plausible alternative explanation for these findings. So in a second type of approach that still uses this observational design, we've capitalized on county level variation in social policies that differentially target LGB populations to study relationships between structural stigma and health outcomes, mental health outcomes, here specifically among youth. So in this study, we were interested in examining whether lesbian and gay youth who live in counties with school districts that have a greater proportion of school districts that have inclusive anti-bullying policies, whether that's associated with lower risk for past year suicide attempts. And another methodological strength of this study is that it's examining social policies below the state level. So that is, here we're interested in county level policies, and that's important because, of course, there's a lot of within state heterogeneity or variability in social policies. So briefly, in this study, what we did is we went through the school anti-bullying policies and looked at the proportion of school districts that had anti-bullying policies that were specifically inclusive of sexual orientation. That is, they listed sexual orientation as a protected class. And then what we did is each county therefore received a score based on the proportion of its school districts that had these inclusive anti-bullying policies related to sexual orientation. And then similar to the first study, we linked this ecologic data on inclusive anti-bullying policies at the county level to individual level health outcomes among youth living in those counties. And these data come from the Oregon Healthy Teen Study. These are annual surveys that are given to over a third of Oregon's 11th grade public school students, and they're modeled on the YRBS data sets from the CDC, which are used to measure the leading causes of morbidity and mortality among youth. And as I mentioned, our outcome measure here for this study was any suicide attempt in the past year. So here on the y-axis is the prevalence of suicide attempts in the past year, and on the x-axis is that inclusive anti-bullying policy variable, here divided into tertiles ranging from the least to most inclusive. So most inclusive counties would be the counties where their school districts had the greatest proportion of policies that were inclusive of sexual orientation. So this is just stratified analyses only among the lesbian and gay youth. And you can see a dose-response relationship here between inclusive anti-bullying policies and past year suicide attempts. And we find that the lesbian and gay youth who lived in the least inclusive counties were 2.25 times more likely to have attempted suicide in the past year compared to those living in the most inclusive counties. And these results remain robust after adjusting for a variety of demographic characteristics associated with suicide attempts and also for exposure to peer victimization. So these studies and others like it were important early on for establishing that there may be associations between structural stigma and health inequalities, but they're of course the weakest in terms of causal inferences because these are cross-sectional observational studies. So in a second methodological approach, we and others have complemented these observational studies through the use of quasi or natural experiments. So these are where we've capitalized on the rapidly changing policy environment here in the US surrounding LGBT populations to study these relationships between structural stigma and health. It's of course, it's somewhat challenging or difficult to do these kinds of studies. I of course can't randomly assign individuals to live in high or low structural stigma environments. The IRB is not going to let us do that. But we can take advantage of these naturally occurring changes in structural stigma through changes in laws and policies to conduct quasi or natural experiments. So one of the challenges in doing this work is you need a somewhat unique data structure where you have, you followed your sample over time, and then there's a shift in the social policy, and then you follow that, continue to follow the sample to see if there are changes in your health outcome following changes in the law and policies. And it's often difficult to anticipate when those policy shifts are occurring, and so therefore it's often difficult to get baseline data before the policy shifts occur. But we've been able to do this in a couple different studies. I'm just going to present one for the sake of time. So in this study, we have to go back to 2004 when some of you will remember multiple states passed constitutional amendments banning same-sex marriage, which was our indicator of structural stigma. And it just so happened that those events occurred in between the two data collection periods of the NESARC, which is the data set that I mentioned for the first study. So the NESARC was longitudinal. Respondents were first interviewed in 2001, and then the same respondents were re-interviewed again 4 years later in 2005 following the passage of the same-sex marriage bans. So this created a natural experiment of sorts that enabled us to examine changes in the prevalence of psychiatric morbidity among LGBT individuals who had been assessed both before and after the passage of these bans. Here's the results. Again, for the sake of time, I'll just be presenting the results for one outcome, mood disorders here, which was a combination of depression and dysthymia. But we also find similar results for the other anxiety and substance use disorders that we examined. So on the y-axis here is the prevalence of mood disorders, and on the x-axis is the state of residence. So on the left-hand side here are LGBT respondents who live in one of those states that banned same-sex marriage, and on the right-hand side were the LGBT respondents who lived in one of those states that did not ultimately ban same-sex marriage. All right, so let's take a look at the results here. You can see at wave one, the prevalence of mood disorders was nearly identical between these two groups, which makes sense because this occurred before the implementation of the bans. However, in wave two, following the passage of the same-sex marriage bans, there was a 37% increase in mood disorders among LGBT respondents living in one of those states that had banned same-sex marriage. And you can see our within group logistic regressions indicate that that's a statistically significant increase. In contrast, there was a 24% decrease in mood disorders among the LGBT respondents living in one of those states that did not ban same-sex marriage. That's actually not a statistically significant change, although you can see here that there is a trend towards a protective effect of living in those states. But what's another way that we can evaluate the extent to which these results are specific to the LGBT respondents who are living in those states that enacted structural forms of stigma? Well, another comparison group is to look at what happens to the mental health of heterosexuals who also live in one of those states that ban same-sex marriage. So let's take a look at those results. So as you just saw on the previous slide, there was a 37% increase in mood disorders among LGBT respondents who lived in one of those states that banned same-sex marriage. But in contrast, there was only a 3% increase in mood disorders among heterosexuals living in those same states. And as you can see here, that's not a statistically significant increase. So we've documented specificity of these findings to the stigmatized group, in this case LGBT individuals, living in those states that enacted same-sex marriage bans. Another variant or type of these quasi-experiments that researchers have used is a somewhat different design. So here they've used cross-sectional panel data with state-level fixed effects to examine associations through the use of a quasi-experimental design between structural stigma and mental health outcomes. So I'll just present one very recent example of this work that Julia Raifman and her colleagues published recently in JAMA Pediatrics. And this is one of the few studies that's been done among youth, which is another reason I chose it. So here they use a difference in differences design where they examine associations between state same-sex marriage policies and adolescent suicide attempts. So what they did here is they compared changes in the prevalence of suicide attempts among high school students before and after those states passed same-sex marriage policies, and compared those to changes in the prevalence of suicide attempts among high school students in states that had not banned, that had not passed these same-sex marriage policies. And one of the unique things they did in this study was to use state-level fixed effects, which control for two things. The first is they control for baseline differences in suicide rates across states. So we know that the prevalence of suicide attempts differs fairly dramatically across states, and so it controls for those differences. And this also controls for time invariant factors like political climate that differ across states that might affect both the independent and dependent variables. And they find fairly large and I think strong findings. So they show that this passage of the same-sex marriage policies was associated with a 14% relative decline in the proportion of LGB individuals, LGB high school students who reported past year suicide attempts. And they also conducted a series of sensitivity analyses, including a falsification test, where they showed that same-sex marriage policies weren't associated with outcomes that we wouldn't expect them to influence. So they looked at things like fruit juice consumption and helmet wearing, some of the variables that are used in the YRBS. All right, so I'm shifting gears now to a different methodological approach that's been used to triangulate evidence to explore these relationships between structural stigma and mental health. So here we capitalize on unique population-level reductions in structural stigma. So the research question here is relatively straightforward. So if structural stigma contributes to sexual orientation disparities in mental health, then we would expect there to be a reduction in the magnitude of sexual orientation disparities following declines in structural stigma at a population level. So it's a relatively straightforward question. It turns out, though, it's quite challenging to test because you need a really unique data structure that exists within a unique social context. So specifically, you need a data set that's repeatedly measured health and sexual orientation over time, which is already quite rare at a population level. But you also need that data set to exist in a social context that's undergone fairly marked declines in structural stigma towards LGBT people at a population level. And it's proven very difficult to find a data set that exists in that social context, certainly not here yet in the US. But one place we've been able to go to study this is in Sweden, which over the last sort of 15 to 20 years or so has undergone a pretty remarkable change in terms of their laws and policies and attitudes related to sexual orientation. So I'm showing here a timeline of some examples of the changes in their laws and policies related to sexual orientation. So just to highlight a couple of quick examples, in 1999, discrimination in employment based on sexual orientation was made illegal. A couple years later, in 2003, protections based on sexual orientation were added to hate crime and hate speech laws. And then finally, in 2009, same-sex marriage was legalized in Sweden. And these changes in laws and policies were mirrored in changes in social attitudes among the Swedish population. So this is data from the European Social Survey. These are nationally representative surveys of European citizens. This is showing the data from Swedish adults. This is the percent that agree or strongly agree with the statement gays and lesbians should be free to live life as they wish. So you can see in 2002 it's already starting at a very high level, certainly much higher here in the US, where 82% of the general population in Sweden agrees or strongly agrees with this statement. And then a little over a decade later in 2014, close to 92% of the population agrees or strongly agrees with this comment. So in order to examine associations between these declines in structural stigma and mental health outcomes in LGBT populations, we use data from the Swedish National Public Health Survey. These are nationally representative surveys of non-institutionalized adults in Sweden. And beginning in 2005, they started collecting information on sexual orientation and identity. And importantly, we showed, first of all, just that the proportion of respondents who are endorsing an LGB identity is relatively stable over this 10-year period. So we're not finding that the underlying distribution of the LGB population is changing much over time despite these changes in laws and policies and attitudes. So let me walk you through the results here. On the y-axis is the percent that met criteria for an elevated psychological distress. And on the x-axis are the 3 different time points in the study. And I'm stratifying the results here by sexual orientation identity, comparing gay men and lesbians to bisexuals because we had a large enough sample size to disaggregate that group, and you'll see in a minute why that was important, and also showing results for heterosexual men and women. So first, just want to show you this dotted line here is our measure of structural stigma. That's just a combined index of the laws, policies, and attitudes showing what I just showed in the 2 previous slides, that decreased over time. So let's first look at in 2005, 2010, and 2015 for gay men and lesbians. So you can see here a pretty marked decline in the proportion that met criteria for psychological distress during this period. For bisexuals, you can see a decline between 2005 and 2010, but then actually an uptick again in 2015. And then finally, for heterosexual men and women, you can see a small change in the proportion that met criteria for elevated psychological distress during this period. So that's just descriptively. In terms of inferential statistics, we first tested an interaction between year and sexual orientation, and that is statistically significant. So that shows that this decline in the proportion that met criteria for psychological distress was significantly stronger for gay men and lesbians compared to heterosexuals. But most importantly was this question of what was happening to the disparity following declines in structural stigma. So you can see here that in 2005, gay men and lesbians are nearly 3 times more likely to meet criteria for psychological distress compared to heterosexuals. But in 2015, that disparity had been eliminated. So these results are preliminarily consistent with this idea that following declines in structural stigma at a population level, whether that's through changes in laws or policies or attitudes, is associated with declines in the magnitude of sexual orientation disparity in mental health. All right, so to wrap up this section, I'll present the 4th and final methodological approach that researchers have used. This is where some of my clinical site training came back in, where we moved from these large-scale epidemiologic studies back into the laboratory to begin to try and test potential mechanisms that might explain this relationship between structural stigma and health. And of course, the advantage here is that you have experimental control, so you can examine how prior exposure to structural stigma affects a variety of different psychological and behavioral and physiological responses to the same stimulus in the lab. So we've been interested in testing lots of mechanisms, but the one I'll focus on today is a stress pathway. And so given our interest in stress, we've been interested in relationships between structural stigma and the HPA axis, which of course culminates in the production of cortisol, which is a stress hormone. And that was our outcome of interest for this study. So in this study, we had 74 LGB young adults come into the lab. They had grown up in 24 different states, and I'll mention why that's important in just a minute. And they were told that the purpose of the study was to understand connections between your daily experiences, your bodily activity, and health. So there's no indication the study was about stigma or the other constructs of interest. And our measure of structural stigma here was slightly different than the ones that I've been presenting before. Before we've used either these separate indicators of laws or attitudes, here we wanted to develop a measure that was more sort of a more comprehensive measure of exposure to structural stigma at the state level. So there were 4 different indicators that we looked at. These included the density of same-sex partner households in the state, the proportion of gay-straight alliances in public high schools in the state, and then composite indicators of laws and policies in the state related to sexual orientation, and also to attitudes towards gays and lesbians held by the residents of those states. So we conducted a factor analysis of those 4 items, and a single factor emerged, suggesting that they're loading onto this single construct of structural stigma. And so similar to what we've done previously, each state receives a score based on the average level of structural stigma in that state. So you can see here, obviously a map of the US showing the distribution of structural stigma, with states that are in lighter blue were the states that had higher levels of structural stigma related to sexual orientation. So what we did in this study was, as I mentioned, these are all young adults. They had all actually moved to New York, a low structural stigma state according to this map. But as I mentioned, we strategically recruited them because they had grown up in 24 different states as adolescents. And these states differed widely in terms of level of structural stigma related to sexual orientation. So what we did is we asked these participants, where did you spend the longest period of time between the ages of 10 and 18? And we did that because we know from the developmental literature that this is the period of time when same-sex attraction is beginning to first be reported, and that when individuals are beginning to identify as lesbian, gay, or bisexual, at least to themselves, even if they haven't disclosed to others. So our research question was, how does prior exposure to structural stigma as an adolescent affect your current physiologic stress response to the same stimulus in the lab? So to test that, our participants completed the Trier social stress test, which I'm sure many of you are familiar with, one of the most well-validated stress paradigms. We tweaked it just slightly, and I'll mention how in just a minute. So participants come in, and once they've acclimated, they're told that they have to give a 5-minute speech in front of 2 evaluators they're told that these are 2 evaluators are trained in the evaluation of speech, and of course, unbeknownst to them, these are Confederates that we've trained to give only neutral feedback, so they don't smile, they don't nod, they don't give any kind of affirmative feedback. And then the tweak that we made was to have the speech, often this topic is what makes you a good friend. We really wanted to heighten the social evaluative threat component of this task and make it more identity relevant. And so we had them talk about a time in which they've been rejected or discriminated against because of their sexual orientation. And remember, they're giving this in front of 2 individuals. They know their attitudes towards sexual minorities. And then, as if that's not bad enough, to me, the most stress-inducing is the 5-minute math task where you're given a preposterously high number and have to count backwards by 7s really quickly, and if you mess up, the Confederate yells at you. So not surprisingly, a meta-analysis showed that this task produced one of the most well-validated cortisol responses. So we collected neuroendocrine samples via saliva at 3 different time points that we assayed for cortisol, which, as I mentioned, is our outcome of interest here shown on the y-axis across 3 different time points. Time 1 is baseline, time 2 is reactivity, and time 3 is the recovery. And these are stratified by exposure to structural stigma as an adolescent. And you can see here that there's a blunted cortisol response among those who grew up in the highest structural stigma states. And that blunted or hypocortisolism has now been observed in numerous samples that have been exposed to chronic life stressors, such as kids exposed to childhood maltreatment, and also individuals with PTSD and other forms of severe trauma. So these results suggest in a preliminary way that the stress of growing up in these high structural stigma environments may be exerting biological consequences similar to other chronic life stressors, and suggests that stress may be one mechanism linking structural stigma to adverse health outcomes. I also want to acknowledge, though, the difficulty of interpreting cortisol as an outcome, given that research has shown that psychosocial stress is associated with both hyper and hypocortisolism. So we're doing a follow-up lab-based study now where we're bringing in more psychophys measures, things like heart rate variability and impedance, where we can examine associations between structural stigma and those more cardiometabolic measures that will help us determine whether those are producing profiles that are similar to what we're seeing in the neuroendocrine system. So before I end with some remarks on future directions, I just wanted to note that researchers have used a variety of different strategies to try and establish causal inferences regarding these relationships between structural stigma and health, because as I mentioned, we can't, by and large, do randomized experiments. And so one of the strategies that researchers have used that I mentioned already is trying to triangulate evidence across different methods, measures, outcomes, and research teams with the eye towards, if you can show consistent relationships, then it shows that this relationship between structural stigma and health isn't confounded by any particular method or measure or outcome. Secondly, researchers have examined the extent to which they are able to document specificity of structural stigma to health outcomes only among the stigmatized group. And the reason that's important is that if you can show that structural stigma is only associated with health outcomes among the stigmatized group, it improves our confidence that those results are due to structural stigma per se, and not to factors that might be associated with it, like, for instance, better economic conditions, that would also be expected to affect outcomes among the non-stigmatized group. Third, researchers have controlled for potential individual and structural level confounders to rule out spurious associations between structural stigma and health. As I mentioned, they've also conducted falsification tests to show that structural stigma doesn't predict outcomes it shouldn't theoretically influence. And then finally, researchers have begun to try and see if there's any evidence for plausible alternative explanations for these findings, like differential selection by health, and by and large, thus far have not found evidence for these relationships, for these alternative explanations. All right, so in the last couple of minutes, I want to spend some time talking about the focus of this on future directions, particularly as it relates to structural stigma and LGBT health disparities. Although, as I mentioned, hopefully you can also think about ways that this might apply to work that you're doing with stigmatized groups that you work with. As I mentioned at the outset, most of this work has been conducted among adults. So I want to spend some time thinking about how this work can advance research specifically on structural stigma and LGBT health disparities among youth. This is the topic of the JCAT paper, and also in a recent paper I wrote in American Psychologist, synthesizing some of this literature and its implications for psychological science. So I'm going to focus on really quickly 5 different key areas that I think are the most important for the field to address moving forward. So the first is to test generalizability of structural stigma to transgender youth. Most of this work has really focused specifically on structural stigma as it relates to sexual orientation. One of my doctoral students, Amaya Perez-Brumer, wrote one of the first papers on this topic. One of the things that's been really challenging to conducting this work among transgender youth is that until very recently, there was very little, if any, variation in laws and policies related to gender identity at the state level. So it was essentially a ubiquitous exposure. But of course, as I'm sure many of you are aware of by now, there's been a really rapid proliferation in laws and policies at the state level related to gender identity. And so I think this is a particularly relevant and important time to study this topic. Secondly, I think we need more research to adopt more of a life course approach to the study of structural stigma and health, given that the vast majority of studies are really only focused on a single point in development. And so therefore, there's not a lot of attention been paid to developmental timing or chronicity of exposure to structural stigma. The study that I mentioned, the lab-based study I mentioned, is one exception to that, where we examined how prior exposure to structural stigma as an adolescent affected current physiologic stress response as a young adult. But I think we need a lot more research on this topic. And one of the ways that I think researchers can begin to address this is to take advantage of naturally occurring geographic mobility in longitudinal cohort studies. So you can examine, for instance, how do LGBT youth who grow up in low structural stigma states, but who move to high structural stigma states later on in development, are they buffered against these high structural stigma contexts because of their prior exposure to more supportive environments as youth? And that type of question, I think, is we're increasingly able to answer because more longitudinal cohort studies are beginning to include measures of sexual orientation and gender identity, like the Growing Up Today study or the GUTS data set that we've begun to use to explore some of these questions. Third is in the area of measurement. I think we need a lot more work to develop and validate new measures of structural stigma, particularly those that are relevant to youth. So we've started to do this in some of our work. So for instance, we collaborated with the Boston Police Department and got access to records on LGBT assault hate crimes at the neighborhood level that we used as our indicator of structural stigma. We've also developed measures of structural stigma as reflected in religious climate and also school climates. As other examples, but I think we need a lot more research to develop other indicators of structural stigma that are particularly relevant to LGBT youth. Fourth, I think we need more research to examine structural stigma within the context of intersectionality. Most research has really focused on structural stigma just related to one single group, which of course obscures the fact that LGBT individuals, like everyone, have multiple identities, some of which may be stigmatized within a particular social context. And so that raises the really important question of whether structural stigma related to sexual orientation interacts with structural forms of stigma related to other axes of social stratification, like race or ethnicity or income or nativity status, to either confer risk for or protection against adverse health outcomes. My colleague John Pachenkis just published one of the very first studies to use this intersectional approach. And what he did is he created a measure of structural stigma related to sexual orientation and also to immigration status. And he showed that they interacted to predict HIV risk outcomes among migrant men who have sex with men. And I think this work is important because it not only advances structural stigma research, but also suggests a different way for us to begin to test intersectionality theories. So the way that the field typically tests intersectionality is by examining interactions between demographic characteristics like race or sex or ethnicity. But the theory is actually about interacting systems of social oppression. So we should be measuring the systems themselves rather than the demographic characteristics they're associated with. And this provides just one example of thinking about how to do that. All right, the last one. This is actually something that I mentioned today during John's great talk earlier, but it's thinking about how structural stigma might affect the efficacy of our psychological interventions. So this is work that Alicia Reed and her colleagues did, and I told her recently she should pay me commission because I feel like I talk about, it's one of my favorite studies, I talk about it all the time because I think it's so important for all the work that we do as interventionists. So as I mentioned earlier, briefly what they did is they reanalyzed a meta-analysis of 78 HIV prevention interventions among African Americans. And they took advantage of, these were interventions focused on, they were CBT interventions focused on reducing HIV risk behaviors. And these studies have been conducted across the US in communities that differ in terms of the level of structural racism in those environments. She measured that in a couple different ways. One of them was to get measures of whites' attitudes towards blacks in the communities where those interventions had been done. And then she linked that measure back into the data set and examined it as a moderator of intervention efficacy. And here are her results here. So on the y-axis is the standard mean effect size of those interventions, and on the x-axis is the measure of structural stigma related to whites' attitudes towards blacks in the communities. This is actually, it's a feelings thermometer, so it's reverse coded. So higher scores indicate lower levels of prejudice. So you can see here in the lowest prejudice communities, the effect size for these interventions is really robust. But in the highest prejudice communities, all the way to the left, you can see that the effect sizes were literally 0 in those interventions. And so this sort of provides, I think, empirical evidence behind our intuitions. We know that our interventions really flourish in some social contexts and fail in others, and suggests that structural stigma might be one, at least one mechanism explaining some of the heterogeneity in intervention response. And so adapting this to the LGBT populations, it suggests that first we need to explore the extent to which this is happening in our mental health interventions with LGBT and other stigmatized groups. And if so, begins to open up, I think, new ideas for how to augment our interventions in high structural stigma contexts to make them maximally effective, even as we continue to target stigma at its source. So in conclusion, our work and others has shown that structural stigma is a risk indicator for adverse health outcomes and that it contributes to health inequalities over and above stigma at other levels of analysis. As I mentioned, we've used a multi-measure, multi-method, multi-group, and multi-health outcome approach here to explore this. And the consistency of these findings, I think, across these different approaches begins to, I think, speak to the robustness of these findings. Although, as I mentioned, I think we need a lot more research to really explore just how it is that structural stigma contributes to health and health inequalities. And then because this is an intervention, or partly intervention audience, I thought I'd just briefly talk about some implications of this work in terms of interventions in a different way of thinking about how this social science work can inform public policies. So in part of my work, I collaborate with other social scientists and lawyers on court cases on amicus briefs for court cases on status-based discrimination. So several of the studies I mentioned today, along with numerous others by other social scientists, have been used in court cases to inform public policies aimed at reducing stigma and improving health at a population level. So I'll just end by acknowledging funding for this work and my many amazing collaborators without whom this work certainly would not have happened. And thanks again for the opportunity to talk to you, and I'd be happy to answer your questions.
We have time for some questions.
Good, I didn't go over.
Thank you for a very interesting talk. Could you talk a little bit in terms of what you see as some of the potential mechanisms from the structural level,
Sure.
factors to the outcomes?
You can tell I get this question a lot, so I've already created a slide. So I think this is a really important area for future research. I think that we have done a pretty good job so far of documenting the main effects, and then the question of mechanism, I think, is an important next step. We have begun to identify some of those mechanisms largely through stress pathways, but also in a couple different ways here. So here's how sort of I think about it. I think about kind of short-term and longer-term mechanisms. In terms of the short-term, I think a lot of these studies are looking at just the short-term influence of these structural forms of stigma on mental health in particular. And a lot of those, I think, have to do with the discourse surrounding the policy shift. And there's some good studies showing these effects of sort of the discourse around these policies and voter referendum and how they affect mental health in the very short term. But then I think in terms of the sort of more longer term, thinking about how structural stigma gets under the skin to produce these adverse outcomes, I think of this as sort of in kind of resource pathways and then psychosocial pathways. And through resource pathways, so many of these laws and policies that I focus on in the sexual orientation space come with really tangible benefits. So for instance, when with marriage, there are 1,132 benefits that come with marriage that same-sex couples were denied, for a period of time that have really financial implications. Of course, you can also still be legally fired in 29 states currently because of your sexual orientation, which also comes with clear sort of financial and SES, pathways. But then there are all the sort of psychosocial pathways in terms of sort of belongingness and integration that I think are important psychosocial mechanisms. So we've begun to actually look at this. I think it's easier to see in this. I've schematically shown these as separate, but of course there are relationships among these different forms of stigma, where structural forms of stigma affect the interpersonal context that you're in, but also affect the way in which you appraise and experience and respond to those stressors at an individual level. And so we've begun to show both kind of direct relationships, meaning structural stigma affects for instance, the extent to which you conceal your identity within a particular, so in higher structural stigma environments, you're more likely to conceal your sexual orientation than not. And we've also shown interaction. So if you live in a high structural stigma context and you're exposed to more interpersonal forms of stigma and discrimination, you're at greater risk for adverse health outcomes than not. So beginning to look at kind of synergistic and direct relationships. So I think these other psychosocial and interpersonal individual forms of stigma are also mechanisms linking structural stigma to health outcomes. Yeah.
Right here on LGBT research.
Yeah.
And stigmatization. I think
Yeah.
it applies to the mentally ill.
Absolutely, yeah. I mean, I have a postdoc right now who's really interested in this very topic. And one of the things that has been challenging is to think of what are the first step is always to create the indicators of structural stigma related to the particular group, right? And so there's actually some good measures over time of people's explicit attitudes towards mental illness around things like perceived dangerousness. He's also using measures from the Project Implicit website, the IAT, and aggregating those up to community and state levels as indicators of sort of implicit attitudes towards mental illness. The challenge has been more in the policy space. there are certainly laws and policies that, even if they're not explicitly discriminatory, yield unintended consequences for individuals with mental illness. And so we're starting to think about the extent to which those are measures that you can use as structural stigma related to mental illness. But I've actually, partly why I asked that question to John earlier is I've been thinking about creating some of those indicators and seeing if they moderate the intervention efficacy for psychological interventions, that the context, the individuals with mental illness don't exist in a vacuum. They're in social contexts that are constantly sending them messages about their identity or their status as individuals with mental illness. And that context that has been shown with other stigmatized groups has not, it's interesting, in the stigma literature, the structural stigma, the idea of structural stigma really came from the mental illness space, but it's lagged behind in terms of empirically showing that structural forms of stigma related to mental illness actually matter for outcomes for individuals with mental illness, things like chronicity of disorder or mental health seeking behaviors, things like that. So I actually think it's a really exciting area to look at in terms of generalizability and thinking about the extent to which these findings from other stigmatized groups apply within the space too. My hunch is, it's an empirical question. I think we've shown enough in other groups to think that it would. It's just now thinking about what those indicators would be and linking them to these data sets and showing that they matter. Yeah.
What are your thoughts on addressing the impact of structural stigma, like clinically, sort of a structural stigma versus the individual and interpersonal stigma?
Yeah.
Or more, like just sort of like the balance of what level you address.
Yeah. So that is a great empirical question, and I think I'm not aware of intervention studies that have tried to, disentangle that question. My colleague, John Pachenkas, has an R01 right now where he's developing, it's a transdiagnostic CBT intervention for gay and bisexual men, and the whole first part of it focuses on the kind of the quote-unquote psychoeducation component is really around what is stigma and how does it operate at multiple levels, and what are the ways that, and people get the kind of, the things like concealment and internalized stigma, that's something that patients tend to have a lot of, that it's easy for them to get. One of the challenges, I'm a co-investigator on that grant, and we've been working with some of the therapists about one of the challenges has been how do you talk about structural stigma? It's this idea that people sort of initially don't get because you don't think about the structures and how those impinge upon the constraints in your life. But once particularly in New York where you have a really migrant group, people can talk about the context where they grew up and how that might have shaped their views of their identity and things like that. So he's incorporated this in. He hasn't. It'd be interesting to do a dismantling study where you randomly assign some patients to get the part of the treatment that just focuses on problems related to structure versus those individual. And in some ways that'd be interesting. I don't know. I think they're also important that it's probably, I don't know that we actually need to do that study, but yeah, so. Mm-hmm.
Yeah, so I was thinking almost more as like a clinician, one might be less prone to address structural stigma because it could feel kind of disempowering. I as a clinician can't change structure.
Yeah.
And I can't help you feel empowered to change structure. I can a little, but it's just, there's like less room for movement, I feel like.
I would challenge, sorry.
Clinicians can be less prone to using
Yeah,
structure.
I think that is right. But I would maybe challenge that idea. I think so. Working with sociologists more, I've come to understand one of the things that in sociology that they really struggle with is this idea of kind of structure versus agency. And I think structure gets a bad rap sometimes because people think that structure means there's no agency. And I would challenge that idea. I think we have lots of good examples of agency within structurally disempowering contexts. And so really encouraging people to be familiar with that. You can look across multiple stigmatized groups, certainly within the LGBT area with ACT UP and others, but in other stigmatized groups as well, the civil rights movement, women's movement, things like that. So I think that there are really good examples to turn to and to make people not feel disempowered. And certainly to draw on some of the literature of collective action in social psychology and how that has been meaningful in terms of buffering, adverse mental health outcomes. So, but I think we should test these things out. That's a great suggestion.
So I want to make sure that we set aside some time for our breakout discussions. So let's give a round of applause to